healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Hey, good afternoon, everyone. I want to welcome you today. I'm your host, Stuart Newsom, and I'm thrilled to have all of you with us here today. Now, if you've never joined, I can tell you right now, our format is all about helping you optimize your revenue cycle. We give a lot of tips. Sometimes we give a little insights. Occasionally, we'll do a demo of some of our solutions, but it's all framed around how can we help providers receive the appropriate reimbursement that they deserve. And so the format, sometimes we bring on clients that will just discuss kind of the things that they've been doing and working on to help fortify their revenue integrity. We also may bring on certain subject matter experts that are within the Infinix organization. And so if you've been on our show before, you know that typically we have a guest. Sometimes I go it alone. Today is one of those days. Originally, we had planned to have Stephanie Chang. Now she's one of our senior customer success managers here, does a great job with making sure that we have happy customers, taking care of a lot of our customers. And she was going to discuss standardizing prior authorization workflows. Well, she came under the weather a little bit yesterday and is just unable to join us today. So we're going to postpone that episode. We're still going to do that. It's going to happen in just a few weeks. But today I wanted to touch on something. I thought I had the idea that I would do something that would preempt what Stephanie's going to talk about. And it's really all about why do prior authorizations get denied even after they've been approved? That's a very frustrating topic. Prior authorizations are frustrating enough, right? So the fact that the prior authorizations get denied even after they've been approved adds to that frustration. It's even more frustrating. I just thought that something that could kind of tee up what Stephanie's going to talk about is all about how you can improve those workflows and standardizing those workflows for your prior authorization processes. This is going to be more about, well, then why are those always denied even once they're approved? And the reason I focused on this is, and I've mentioned this before in various webinars as well as speaking events that I've gone to, that the top denials are always released. Every payer does it, Medicare especially does it. You can get those stats anywhere. And we're finding with prospects that it kind of mirrors what the national averages are. But the number one denial always seems to be prior authorizations or denials due to prior authorizations. In fact, the last couple of years, it's been 50% of the denials. So not only is it the top denial, it's almost half of the reasons that claims are denied. And to me, that's just crazy, especially if it's been approved, right? And you should have no problem getting paid. Now, if you didn't get a prior authorization and you get a denial code due to lack of prior authorization, then shame on you. Shame on us, right? Because there are things in place, there are parameters in place. As frustrating as it is, and again, that's something Stephanie's going to touch on in a few weeks on how to mitigate that. It's still something out there that's all about cost management. I think it's a good idea, or at least the mindset around prior authorizations is a good idea. Trying to control cost management, making sure that this is going to be a covered service, understanding what the patient's responsibility is ahead of time. All of these are factors that it's really good to know up front. And as long as you know them up front, then as long as you get paid in the end, then absolutely no problem, easy peasy. But I can tell you that, and I've also stated this before, I believe it's in an episode that we did about a month ago. We discussed how $10.6 billion in denied claims and what was the result of that and how that was being recouped. They were going back and recouping the money from that. And from that, we discussed how just for whatever reason, most payers will deny on average 15% of claims. And the main reason, because they can, because they want to. It's just something they do. I know they give you these CARCs and these RARCs and these reason codes, and there's a whole other process that we can talk for another hour on about how you can utilize those CARCs and RARCs and get to the root causes and be sure you mitigate those denials. Considering the fact that they just deny claims anyway, just because they can, is really kind of absurd. I think everyone would agree with that. But another reason why payers may deny for no particular reason that doesn't make any sense is there's a lot of misinformation within the payers themselves. I think there's a lot of assumptions that the payers have it all together. They have all these rules and guidelines in place, and there's a lot of sharing of information going on within the payer organization. Like I said, that's not the case. Many of you may be nodding your heads right now, and you've had a lot of experience speaking with payers in the past and understand this full blown. We just actually spoke with a prospect just this week that was frustrated with this. So there's a lot of discontinuity within the payer organization where the left hand doesn't know what the right hand's doing. For instance, this particular scenario with this prospect is that she knew what was covered, what covered procedures were, but she also would call in through those manual processes, dealing with phone calls and trying to connect to get the prior authorization done. As we all know, it's a very laborious process. And even though she knew that there was covered services for what she was trying to submit it for, she still would go through the process to make sure she got that prior authorization. And so she had a list of what was covered services, and they were agreeing. So, yeah, you're granted prior authorization. This is approved. And then when she turned around, she got the denial, and the denial would actually indicate to her that no, this is an experimental procedure. Okay. So after a few times of this going on, she finally got someone on the phone and said, "Okay, do you understand that you've just agreed that this is a covered service? I'm looking at your policy that this is a covered service, but do you realize that you're going to deny it as experimental?" And the person on the phone had indicated to her, says, "No, this is approved." The person on the phone had no idea that this was on the back end. So there were instances where there was two different entities within the same payer that were functioning like this. And it's kind of like a practice. And we'll get to this at the end a little bit, but sometimes there's silos within practices where certain departments won't communicate with each other. Well, it's the same thing with payers. They're siloed. Everyone has a certain job to do. They put their head down and they do that job without looking up and seeing exactly what the considerations are around them. So, with that in mind, there are a lot of disparities with discontinuity with the payers and the fact that they just flat out deny claims. Again, because they can. And again, on average, that's about 15%. Now, I will say there are some legitimate reasons that this is happening. So we'll dive into some of those reasons behind that statistic of why it's 50% of denials are based on prior authorizations. But the first reason has to do with change in patient's coverage. Now, that's just a nemesis that practices forget to check. They take for granted that the patient came in to see the physician. They ordered these tests, or they ordered these procedures, or this surgery was scheduled, or whatever it is. They go ahead and apply and get the prior authorization. It gets approved, and then the patient comes back in to get admitted to for the surgery, or maybe it's an outpatient type of a deal, or maybe it's just a test. And then the insurance has changed for whatever reason. The patient may have switched jobs, either willingly or unwillingly. You know, people get fired. And so unless they're on that COBRA plan, which can be very expensive for them, then their insurance may have changed. Then their plan details may have changed. So the new insurer may not honor that previous prior authorization. In fact, I know they're not going to honor that. So this can be a significant issue leading to unexpected denials. So changes in insurance coverage are a very frequent cause of denials as each insurer has different criteria and coverage policies. Now, obviously, the way to remedy that is not only to ask them if they've had to change insurance, because obviously you can do that. Many practice, just about every practice does that. That's routine. But are they really telling you that they've changed insurance? That's where insurance discovery comes in. That's where you need to run that eligibility and make sure that you have that coverage, that they are insured or that they are a beneficiary of that insurance policy. And what does their plan details? What is their copay? What is their co-share? What are all those details that need to know? And don't take for granted that it's the same insurance for when they come in again. So it's really good to have that done ahead of time. So you know ahead of time, wait a minute, we got to do this prior authorization all over again, which actually delays everything. So if you don't do that, however, then you're just giving away the service for free. You're not going to get paid for that prior authorization because it'll be a denial. The reason is authorizations expire. So just like claims have timely filing, so prior authorizations, they don't last forever. They're not perpetual. You can't just get one prior authorization and just last until the surgery is complete. So if the surgery is not scheduled within those timely limits, then it's gonna expire. And if you go through the surgery anyway, then it's gonna be denied. So providers really need to keep track of these dates to avoid those denials due to any expired expiration. So ensuring timely administration of services within that authorization period is crucial to avoid any unnecessary denials. Now, another is also where the services are just not matching the authorization. I'm going to touch on this a little bit later as well, but the actual service provided must match what was authorized. Now, that seems pretty obvious, right? But any discrepancy changes in the specific procedure or medication can result in that denial. Many times there's perhaps the diagnosis code is billed with the claim that was not originally dictated from the documentation for the reason for the prior authorization. So in many instances, you got to have that correlation. You got to have your own continuity. We discussed the discontinuity of payers earlier on. Well, let's talk about that discontinuity on this end. So what your patient access personnel did, what your intake people were doing, your prior authorization team, whatever information they used to obtain that prior authorization needs to also match with what's going on with the claim. Then another reason is there may be an emergency of changing the procedure, either during the procedure as the physician is performing the surgery or performing the test, whatever the case may be, or even prior to, just prior to. So going on here. For example, an authorized laparoscopic surgery might need to be converted to an open surgery due to complications. That's a pretty common one. And so that, believe it or not, that one little change, I mean, you're accomplishing the same thing, literally, but rather than laparoscopic, you're going in with open surgery, but it's a different CPT code. And you just don't need to give them a reason to deny, right? Now, even though it may be the same means to the end, you have the same diagnosis, but mitigating circumstances caused the physician to actually go in with the open process. You're just giving them a reason to deny it because the codes just don't match up. So, any unforeseen complications often necessitate these changes in treatment plans, which can result in denials, but just make sure that you promptly update the information to the insurer. Again, any addition of new treatments for some prior authorizations do have, like I said, we talked about time limits, but they do have frequencies attached to them. And it may be like 6 months worth, maybe 6 visits, or even especially with certain medications, certain injections, things of that nature. If there's any change in that treatment plan, then that authorization does invalid because you've now changed the plan. You need to update that prior to authorization once the plan is changed, reflect those treatments, and you can avoid denials with any of those new medications, new therapies, or what have you. So it's just very important that you keep up with that keep track that if there's a change, maybe with chemotherapy, things of that nature, that you document that change, and then you'd have to go and get and update that prior authorization or acquire a new one. Otherwise, you'd expect to be denied, where the right hand doesn't know what the left hand's doing, essentially. So let me give you a some other things where you can actually help with this. So there's are some steps that you can take, particularly with documentation. So you want to thoroughly document the clinical necessity for the change in the procedure with an operative report. This should include the reason for the change as well as any complications. So you also want to be very proactive with that. A lot of prior authorizations, I think Stephanie may touch on this as well. If you already understand that typically these prior auths, you do them over and over and over again, you become accustomed to what they're looking for. If they typically ask for clinical documentation, to go ahead and supply that clinical documentation. If there's any change in the procedure or any change in the treatment plan, go ahead and document that and be proactive to send that in because you really need clinical justification. It all comes down to medical necessity, just like anything else does. So you want to include clear, detailed notes on why the could not be completed and why the new procedure was necessary. And you also want to code appropriately. You want to use the correct CPT codes, use the correct diagnosis code, and then modifiers come into play. You can use modifier 22, which is increased procedural services. There's also a modifier 58, positioned during the same post-operative period. There are certain modifiers that you want to use, and you want to use those appropriately. All right. So now I do want to give you a scenario of, or just an example of how this would actually go down. So just consider the fact that a patient is scheduled for a laparoscopic colostomy. All right. So during the procedure, or I should say a cholecystectomy. So during the procedure, the surgeon encounters some unexpected complications such as a severe adhesions that necessitates converting the surgery to an open cholecystectomy, right? So some of the coding steps you need to do is first of all, absolutely necessity. You need to take a look at the operative report and it should detail the reasons for the conversion, such as the presence of severe adhesions and the risk to patient safety. Then you can use modifier 22 in assistance. So add the 22 modifier to that CPT code for the open cholecystectomy, which is actually code 47600, to indicate the increased procedural services. Then you want to submit the documentation with it. Be proactive. You know they're going to ask for it. You know they're going to send it back to you and have that good old fashioned CO16, right? That's that Clark and Wart where it's like we need additional information. So you need to submit the claim with the code, with the modifier, and attach the diagnosis code as well in order to support that documentation, such as preoperative imaging or any showing of the adhesions, any documentation you can, send it on. Now, I've always said that coding is a language. You have the clinical language and then you have the business language. The language that the that what happened at the encounter, what happened, what were the circumstances, it's all in the coding. So obviously you may use the same diagnosis code as to why you had to make this change, but you may have additional diagnosis codes as well. Like you may want to code those adhesions. So many times people forget that when they're submitting the claim, they're still sticking with that original diagnosis. So it's really the small details that matter. And so you just need to take a look at the documentation and code appropriately. If you don't, then you're telling the payer a totally different story of actually what happened. Now, also, what can happen here with denials is the failure to complete required pre-treatment. And this is all on the patient, particularly. These next two are on the patient, particularly. So, insurance will often require patients to try a less expensive alternative before approving a more costly treatment. So, if a patient skips any of these steps or skips any required physical therapy before surgery, then the claim for a more invasive procedure can be denied. So insurances commonly mandate step therapy, so to speak, where patients must try and fill cheaper options first. So it's all about that cost management, like I talked about before. So any non-compliance with these steps can lead to denials. And also for non-compliance with pre-procedure testing. And we all know if there, especially if it's a major surgery, there's a lot of prerequisites that need to go into that. So for certain surgeries, these pre-procedure tests and treatments are mandatory. If these aren't completed and the patient just doesn't get them done, then the prior authorization could be rendered void. All right. For example, a knee replacement might be denied if the patient didn't complete the prescribed physical therapy sessions beforehand. So and according I got this from an article in Medical Economics, according to them, ensuring that all pre-procedure requirements are met is crucial to prevent denial. And then lastly, there's all these administrative and technical errors, right? And this kind of gets into the nitty-gritty of the coding and the documentation I've been saying so far. But I can't stress this enough, and everybody knows this. Anybody in healthcare has heard this saying, if it's not documented, it didn't happen. Many times that they think that applies to E&M coding, but it also applies to obviously surgery and operative reports. Again, the documentation substantiates what is coded. And the coding also details what happened in the documentation, and all of it should reflect what actually occurred during the office visit, during the procedure, whatever's going on in it. All right. So incorrect billing codes or missing patient information are common reasons for denials. It's always been one of the top five. Incorrect billing or missing patient information in documentation. So accurate documentation and double checking denials can prevent these issues. And this emphasizes the importance of accurate and thorough documentation to prevent administrative denials. Talk about policy changes. Okay. How often do the policy changes for you guys? I've seen them change on a monthly basis. I've seen some policies that don't change at all and probably should change, but there's always new procedure, new techniques, there's certain modifications, new CPT codes come out. Every time the CPT's codes are changed, or some are deleted, some are brought on brand new. Certain diagnosis codes change. They got to go back and look at all those policies and change those policies. And they don't do them all at once. They change gradually. I can remember when COVID hit back, 4 years ago. There was all these policy changes that were occurring fast and furious regarding vaccines, regarding even the codes for COVID, even diagnosis codes. And so, but they didn't happen overnight. So many times the insurance companies couldn't keep up with that. But then when they finally did catch up, guess what? The claims got denied that they and so the same thing happens with prior authorizations. You may get a prior authorization that is good and it's approved, but because the policy didn't change in cadence with the actual timing of that prior authorization, the time the service is rendered, they're going to deny that claim. Now, I know that's not fair. To me, I think the right thing to do is, well, we approved this before the policy was changed, so therefore you can proceed with the procedure. We'll pay your claim. But again, giving them any reason to deny a claim, they're going to take it. They're going to take it. So you just need to make sure that you're checking those policies. And if the policy changes, you need to go back and kind of reflect with that prior authorization, update that prior authorization accordingly. Now, another big factor here on how you can mitigate this is be sure that you have some connectivity in meetings and updates. I always say that it takes everyone rowing in the same direction. You're in the boat and everyone's paddling because it's the same boat. Everyone's in that boat. So you have to always get along. You have to always share data, share information. The more information you share across departments, breaking down these silos, the more successful you're going to be. And in this particular instance, when your denials management team on the back end, they're maybe managing the AR and denials management as well. Just if they see a denial due to prior authorization, they ought to be doing this with all departments, but they need to go back to the patient access team, go back to the intake team, go back to the team that does prior authorizations and have a meeting with them and say, look, I know you got the prior authorization, but we got this denial. Let's analyze and look at why this was broke down. And you really see that it's not something that's pointing fingers at each other. It's really an attitude of, hey, can we correct this together? What can be done on the front end to prevent this? And what can we do on the back end to let you guys know, hey, some positive trend we're seeing? You can also do this with the intake team that checks insurance and eligibility. Same thing. You want to make sure that, hey, this prior authorization may have been due to the fact that insurance had changed at that time. Let's be sure that we're checking to make sure that insurance is updated. So when you have that collaboration like that, then it's very key, and you'll be surprised how much it will improve the actual denials and the reduction of denials, not just overall, but particularly with prior authorizations. And there are tools out there. We have tools that can help with that. Obviously, we have a prior authorization platform. We have an insurance eligibility platform. It's a whole patient access platform that we call Patient Access Plus. We also have an AR denials management platform that can actually look at your denials and break down your denials and do it from an analytical standpoint and even do some predictive analysis on which denials you need to work, or also in the front full automation for prior authorization, direct connectivities with APIs to kind of make everything easier. And they can be in sync with each other, where you're looking at both the front end and the back end to help mitigate a lot of these claims in the long run. So basically, hopefully, I've given you a lot of insight and information during this period of time that prior authorizations denials, even after initial approval, are significant challenges in healthcare. There always been a challenge. I mean, I've just heard stories after stories from our clients, from prospects, from people that I see when I go to conferences or just have conversations with CFOs, all the way down to patient access people, even denials managers or VPs of RCMs. They all really are singing the same tune, and it's really just such a headache. So, but understanding the underlying reasons and taking proactive steps to address them, healthcare providers can really improve their PA processes, meaning prior authorization processes, and really ensure better patient care. And everyone will be happy. That's what we're looking for. We want everyone to be happy in the healthcare world, but you just have to do it together. And so, with that, I'd like to turn it over for any questions that anybody may have. But at any rate, one thing that comes up when we talk about the processes and how to make things easier is that aspect of automation. So this is not necessarily a question, but just another observation that I can share with you. And I touched on it a little bit there at the end, but automation is really key right now because of people are just not returning to work, especially in the healthcare field. Still, there's some holes to be filled for the great resignation, so to speak. And so automation is key to that, where not only do you want to automate certain things in silos, because y'all always talk about silos with personnel, but sometimes automations, everyone's out there building all these automations now. And from our perspective, you need to build them across the full continuum of care within your healthcare organization and make sure that whatever automation you're building, consider how it's going to affect another department, how it's going to affect that claim upstream, or what automation you're building is going to could be rendered and helpful for downstream. So from the patient encounter, which starts from the scheduling all the way to the denials management side and getting paid, that automation, if you're building one automation, how does that affect the whole gamut? So just a piece of advice there. You just want to make sure that you consider that. All right. So here's a question we have from Regina. So what conditional steps be taken to overturn denials due to CPT mismatch, where one CPT was authorized and another CPT was billed, and the billed CPT required authorization? Yeah, that's a great question. And there are some remedies. Again, that's when I see that, that's where one hand is not knowing what the other hand's doing. Again, kind of talking back to those silos. It could be where that prior authorization needs to follow that record as it should. And it probably does in this instance, but then that CPT needs to be is what billed. And if it wasn't billed, then why? Was there a change in the procedure? Did the physician take a left turn for legitimate reasons and do a different procedure or a different method, a different approach, so to speak? For any reason that CPT was not billed, well, you went ahead, especially if it was during the procedure and had to be done right then. Well, now you have to really support that documentation. There had to be a legitimate reason why that physician changed their mind and went to a whole nother procedure. And you have to then diagnose that. You have to tell them, why is this the case? To go ahead and supply that documentation and get that required. But if you're just wanting to make sure that the CPT that was authorized gets billed, then make sure that CPT code follows that record and the diagnosis code, the CPT and the diagnosis code. And if someone catches that, a coder could probably catch that, or some automation, like I was talking about before, could catch that kind of somewhere in the workflow, then you could actually take a look at that and say, wait a minute, we need to go back and do another prior authorization. It's better to reschedule, other than the fact that if it's crucial and life threatening for the patient, than it is to get a denial in the long run. And I hope that answered your question, Regina. Now I think there's a J cost, and I think it's Gianna cost, right? I think I remember seeing your registration come through. That we often see denials due to patients not completing lower levels of care first. Yep, exactly. This issue is that by the time they need us, they are critically ill, and the lower levels of care will no longer touch them. How can we navigate that? Wow, yeah, that is yeah, I did cover that a little bit, but going into more detail, because your question does really elevate this, as they do get more critically ill. And I read a story preparing for this particular session where there was a patient who just kept going in, and her prior authorizations kept getting denied. And then when she got real critical ill, she went to the emergency room, she got admitted, she eventually passed away because those previous prior authorizations just didn't take through. That's the case where she kept getting her prior auths denied and no one would treat her until she actually got, like, real sick. It's almost like medicine and health, or the healthcare system is set up where you gotta be really, really sick to get any treatment. And they're trying to change that. I think the quality of care with MIPS and value-based care kinda coming in and inserting, into the threshold, it's really supposed to be what it's supposed to do is help the care of the patient before they get that critically ill. But then the patient has to do it. The patient has to comply. And at the end of the day, you really can't force a patient to comply. They just got to do it. Now you can use scare tactics. You can tell them, "Hey, this is what's going to happen to you if you don't do this." And those lower levels of care are less expensive. But it's just habit. Humans we're just creatures of habit, and we also sometimes do things that aren't really good for us, especially if we have certain conditions. So it's just a constant education, constant telling them that, hey, you need to, have these habits. You need to also take this medication. You're going to be better off in the long run. Else, you're going to be worse off. And then by the time we do get you, your prior authorization may not clear in that instance. So, Janet, I hope that answered your question as well. Okay. Well, I really appreciate everyone joining us today. As always, please come back and see us. I do want to mention before I close out that we just got syndicated with Healthcare Now Radio. So subscribe to Healthcare Now Radio and you can hear us there as well. And we have a lot of content out there based on not only prior authorization and denials, but also on coding, tips on from anything from pharmaceutical, dental, you name it. There's just a ton of content that we've covered over the last several years that you can find in the medium of podcast as well as on our website with our webinars. So happy to have all you join us. Be looking forward for Stephanie to join us next week. I believe we're going to talk a little bit more about the ERISA rules. So that's going to be a real fun one as well. So looking forward to seeing everyone. Thank you for joining us.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's infinx.com.